Because the life tables have been really well developed, so even in a 75-year-old patient usually lives an average of 10 more years. That means many go 20 or 30 years beyond that. Even the average 90-year-old has 4 or 5 years in front of him or her. That's the average. So you have more centenarians, you have more people living, much longer than they used to. So my feeling is, my emphasis is that we really need standards to assume that people may live much longer and not just be moribund in some miserable existence because we made them live longer, but live with outcomes that they would choose to have in the state of living longer. So right now we have a whole research industry that tends to look at outcomes that are very narrowly defined as disease specific. So as a cardiologist, I will think particularly of coronary disease or heart failure. We have a whole algorithm of care. But I think one thing is to start thinking of clusters of disease. It's usually heart failure in combination with atrial fibrillation, like other cardiac diseases, but also in combination with lung disease, COPD, or renal disease. So I think that first step is to think of aggregates, holistic perspectives of patients. And the second thing then is to think about medications in aggregate. And the problem right now is that most trials work very hard to have patients that have narrowly defined disease processes, because that's the best way of studying one new drug. And frankly, the people that invest in trials do this very intentionally because they want to look at the benefit of adding in one drug. And so I think one of the first steps is to really insist that research itself has to change. So we need to include a significant number of patients that have multimorbidities, that are on multiple drugs, that have predisposing factors towards confusion or frailty. Frailty is a big element that's kind of a relevant dimension, because frailty, which is characterized by loss of muscle mass and various other features, really defines patients that are particularly vulnerable to some of these bad things happening. So I think rather than exclude those patients from research, they should actually be included as a dimension of care that we have to treat. One of my peeves really is that the FDA even, which is charged with promoting safety, the FDA does not insist that drugs prove themselves as being safe for older patients. It insists on proving drug safety for those that are pregnant. It looks safety for kids. But again, we have a predictable pattern of older patients with changes of their metabolism, changes of other attributes that make them most vulnerable. And the FDA does not have a standard which insists that, that every label has something which says if you are over 85, you should do this or that, or risks may go up. We don't have those standards. So I think we could really change research on a fundamental level to better inform, our patients.